Dear colleagues and friends, on behalf of the organizer, I'm going to welcome you to the thyroid and parathyroid session, which I'm going to share. In this session, we are going to talk about treatment of hyperthyroidism, about trend of therapeutic application of radioiodine in the management of thyrotoxicosis in the Bangladesh scenario, and about the dual tracer radionuclide imaging in hyperparathyroidism. Several words about the speakers. My name is Raluca Mititelu. I'm coming from Bucharest, from Romania. I'm consultant in nuclear medicine and working in the Central University Emergency Military Hospital in Bucharest. I'm the President Society of Nuclear Medicine and Molecular Imaging and the President of the Nuclear Medicine Board in Romanian College of Physicians. I am also the member of the governing body of WORM. Professor Faridul Alam is from Bangladesh. He is Vice Chancellor of Bangladesh University of Health Sciences. He has 32 years practical experience in clinical medicine, nuclear medicine, and research, mostly worked in National Institute of Nuclear Medicine and Allied Sciences. He used to be professor and director of National Institute of Nuclear Medicine and Allied Sciences and project director of Bangladesh government newborn screening project for congenital hypothyroidism. He is also founder member of Nuclear Medicine, Thyroid and Ultrasound Society of Bangladesh and executive director of Bangladesh Journal of Nuclear Medicine. He has more than 100 publications in national and international journals. Qaisar Siraj is from Kuwait. He is senior consultant in nuclear medicine and PET-CT in Farvania Hospital in Kuwait. He graduated from Dow Medical College at the University of Karachi in 1977 and later gained his master and doctorate in nuclear medicine from the Royal Free Hospital School of Medicine, University of London. He has worked in the specialty of nuclear medicine for 38 years, including 32 years at consultant level. Dr. Siraj is a founder examiner of the Asian Nuclear Medicine Board and IAA expert in nuclear medicine and has worked on certification and quality panels in the General Medical Council UK. He is editor-in-chief of the World Journal of Nuclear Medicine and the founding editor of the Pakistan Journal of Nuclear Medicine. He is also the author of numerous refereed journal publications. All this being said, enjoy the session and ICRT continuously. Bye-bye. The paper I'm going to present today is about the possibility of treatment of hyperthyroidism. Many discoveries in science, technology, or other domains began with an eureka moment. For nuclear medicine, this moment was definitely in November 36. This happened when Dr. Saul Hertz, here in the image, asked Carl Compton, the president of MIT at that time, could iodine be made radioactive artificially? This moment can be considered the beginning of the theragnostic saga. Firstly, non-cyclotron iodine 128 was created at MIT by E. Roberts. Then iodine 131 was produced in cyclotron. Initial study on rabbits showed that hyperplastic glands retained more radioactive iodine than normal, and first ever radionuclide treatment was performed in 31 March 1941 with iodine 31. Let's now start with some definition in order to precisely differentiate between thyrotoxicosis, thyrotoxicosis with hyperthyroidism, and thyrotoxicosis without hyperthyroidism. Thyrotoxicosis is a condition in which there is an excessive amount of thyroid hormone due to endogenous or exogenous causes. It has multiple etiologies and potential therapies. And we have to distinguish between thyrotoxicosis with hyperthyroidism, which is characterized by excess thyroid hormone synthesized and secreted by the thyroid gland. It shows normal or high thyroid radioactive iodine uptake, and is named also true hyperthyroidism. And the thyrotoxicosis without hyperthyroidism, which means you have circulating hormone because of extra thyroidal sources like endogenous struma ovari, metastatic differentiated thyroid cancer, or exogenous factitious thyrotoxicosis, for example. It also can show up, this thyrotoxicosis, in the presence of the release of preformed or stored thyroid hormones into the circulation with low thyroid radioactive iodine uptake. in the thyroid scan. It happens usually because of autoimmune processes or infections. True hyperthyroidism or endogenous hyperthyroidism usually accounts in 5 to 8% in Europe and 1 to 3% in USA, depending on the person who made the analysis, of course. Its prevalence increases with age and is more frequent in women. There is higher incidence of mild forms in iodine deficient areas. True hyperthyroidism is usually accounts because of Bezadov-Graves disease, which is diffuse disease, or because of a nodular thyroid disease, or less common because of thyrotropin-induced thyrotoxicosis and trophoblastic tumors. For Bezadov-Graves disease, the most common cause represent of thyrotoxicosis, it shows up mainly in areas with no iodine deficiency. Is an autoimmune disease with genetic predisposition, accounting more often in women. Psychological factors are usually incriminating, and smoking and some others. And of course, it's high production of thyroid hormone because of high production of stimulation of TSH because of the TRAP antibodies. Nodular thyroid disease is represented by toxic multinodular goiter, in which prevalence increases with age, or toxic adenoma, plumber disease. It is more prevalent in older population in area with iodine deficiency. It accounts in autonomous hormone production, which can be caused by somatic activating mutations of genes regulating thyroid growth and hormone synthesis. Thyrotoxicosis affects virtually and influence almost every tissue and organ system in the body. If not treated or bad treated, it will complicate with weight loss, osteoporosis, atrial fibrillation, embolic events, muscle weakness, tremor, neuropsychiatric symptoms, even cardiovascular collapse and death. The most often we find ophthalmopathy. 25% of cases present with ophthalmopathy. It has special importance in severe forms where should be treated in specialized clinics, these ophthalmopathies. It also have some signs and many signs of which are showing increased adrenergic stimulation like tachycardia and anxiety. And these signs are often pathognomonic for the thyroid pathology. Selection of appropriate treatment is based on precise diagnosis, and is of course influenced by coexisting medical condition and of the patient preference. In the diagnostic algorithm, depending on author and on the journal studied. For example, this article in Lancet said that for definitive diagnosis, we should use either a thyroid scan or thyroid ultrasound, depending on preferences. On the other side, a thyroid scan is telling us by a guideline of American Thyroid Association. They said that a thyroid scan should be obtained if clinical presentation suggests a nodular disease, plumber or toxic multinodular goiter. Scintigraphy, in European Thyroid Association guideline, scintigraphy of the thyroid is suggested when thyroid nodularity coexists with hyperthyroidism and prior to radioiodine therapy. Thyroid scan can be made with iodine 123 or 131 or with technetium. The uptake is performed together with a scan. It will show diffuse uptake in Graves' disease or focal uptake in adenoma, multiple area of focal increased and suppressed uptake in multinodular goiter. Special attention should be, and we have to be very careful on Graves' disease, which is associated with non-toxic nodular goiter with positive TRAP and nodular ultrasound, like in this case, or heterogeneous uptake images. We have some option of hyperthyroidism treatment: antithyroid medication, radioactive iodine, and surgery. We are going to choose between all the three of these in function of the clinical situation, of logistic, of the cost, time to recovery, which is expected, or potential side effects. These are all factors which are going to influence our decision, our therapeutic decision. And of course, we are going to talk to patient and to see which one is most appropriate for him or for her. For Graves' disease, we can use radioactive iodine. This is preferred method in USA, with a slight decrease, of course, in preferences in recent years. Antithyroid medication is the preferred approach outside USA, in Latin America or Europe or Japan, and of course, surgery for some form of the disease. As I mentioned before, we have to be very careful if we have Graves' disease with coexisting thyroid nodules. And we have to take into account that cancer probability in less disease and in Graves' disease is less than 2% in these patients. However, hypofunctioning nodule of 1 or 1.5 centimeter have definitely indication of fine needle aspiration. Other guidelines for thyroid nodules and differentiated thyroid cancer is also published. So probably we should follow the guideline for this particular situation. There are some indication which can favor one or other modality, and we can orient in function of this clinical situation. For example, radioactive iodine is indicated if the patient has comorbidities and the surgical risk is too high. Is also indicated in patients that have previous neck surgery or external radiation therapy, or if there are contraindications to antithyroid use or failure of antithyroid treatment. And one of the approach in Europe, for example, is failure of antithyroid treatment for a long time, indicate automatically or sometimes radioactive iodine therapy or surgery. For antithyroid disease, antithyroid treatment are usually indicated if there is a high likelihood of remission. For example, if we have a patient with mild disease or small goiter or no titer or low titer of TRAP antibodies, or pregnancy, or in elderly where comorbidities involve a high surgical risk. Or, for example, we can prefer this method in case of inability of patient to follow radiation safety regulation, for example, in nursing homes or something like this. And in moderate to severe active Graves' ophthalmopathy this is also an indication almost categorical for antithyroid. Antithyroid drugs are indicated as a first-line treatment of Graves' disease, particularly in younger subjects, and for short-term treatment of Graves' disease before radiation therapy or thyroidectomy. Surgery is definitely indicated in large goiter, which involve compression. If we suspect thyroid malignancy or thyroid malignancy is demonstrated, if there are large thyroid nodules with low function on thyroid scan, if it is also hyperparathyroidism associated pathology requiring surgery, or in moderate to severe active Graves' ophthalmopathy. Hyperthyroidism due to nodular disease, toxic multinodular goiter, or autonomous toxic nodule. According to the guideline of American Thyroid Association, we can rely on the first two. because in this case, they recommend long-term antithyroid only in selected cases. Surgery, for example, they recommend it, and they said that the risk of treatment failure is, of course, less than 1% following near total and total thyroidectomy, and euthyroidism is achieved within days after surgery. It has better results in large compressive goiters, but this also have something to do with logistic, because if you do not have a very specialized surgeon in the area, it's not indicated. It is indicated because of this indication of near total and total thyroidectomy. It is better to have a very specialized surgeon to do this kind of operation. For the radioiodine therapy, there is 20% risk of retreatment in toxic nodular goiter. The response rate is 50 to 60% by 3 months and 80% by 6 months, according to this research. And it is considered that overall the success rate of radioiodine therapy, success means definitive hypothyroidism or euthyroidism, is 81.1% in toxic multinodular goiter patients. For the thyroid adenoma, surgery is also very much recommended because the risk of treatment failure is very low. Why it is this failure? It is because usually they do surgical resection, lobectomy, or isthmusectomy. It's not nearly total thyroidectomy. So that's why probably this risk. Hypothyroidism will show up in 2 to 3% following lobectomy for a thyroid adenoma, lower after isthmusectomy if isthmic localization of the nodule. There are potential complications associated to all thyroid surgery, like hyperparathyroidism or recurrent laryngeal nerve lesions, which of course can be diminished if the surgeon is highly specialized. For the thyroid adenoma, we have in option the radioiodine therapy, which can be preferred in some situations. The risk of persistent hyperthyroidism in thyroid adenoma treated with radioiodine is 6 to 18%, depending on the research. There are 3 to 5.5% risk of recurrent hyperthyroidism, and there are 75% response rate by 3 months and 89% rate by 1 year following radioiodine therapy, according to the literature. Hypothyroidism has a progressive prevalence from 7% at 1 year to 60% at 20 years, which is, I think, a marker of the success of the therapy. Overall, it is estimated that the success rate of radioiodine therapy in thyroid adenoma is 93.7% in thyroid adenoma patient. There are, of course, there were attempts of alternative or future therapies like ethanol ablation or radiofrequency ablation, but unfortunately there is insufficient evidence for recommendation of this method to be continuously used on a routinely basis. There are also ongoing clinical and preclinical trials which evaluate novel therapies that could address pathogenic mechanism of this disease, like monoclonal antibodies or immunomodulatory peptides and so on. We are going to see if these clinical trials are going to bring an alternative, viable alternative to what we have at present. At present, both American and European guidelines affirm lack of sufficient prospective randomized trials to compare efficacy and cost-effectiveness of antithyroid drugs, radioiodine, or surgery. Guidelines make recommendation. Final decision is definitely taken after carefully judging the clinical situation of any particular patient. Evidence-based algorithms are definitely required based on scientific prospective work. Thank you very, very much for your attention and enjoy the session.
Hello, good morning to the global viewers of the virtual 5th International Conference on Radiopharmaceutical Therapy. I am Professor Faridul Alam from Bangladesh. I am going to present the trend of therapeutic application of radioiodine in the management of thyrotoxicosis, Bangladesh scenario. I like to thank the organizer, the WORM and ICRT for giving me the opportunity to be here with the distinct audience of the world. I like to thank all the person who are with me and with the organizer. Thank you very much once again. The Bangladesh is a very small country in the South Asia, 144 square kilometer, having a population of 175 million. And it's a very thickly populated country, having 134 person per kilometer. This is the highest in the world. And we have another record that is the world's biggest sea beach in Bangladesh, that's the Cox's Bazar, and biggest mangrove forest of the world, which is situated in the southern part of our land near the Bay of Bengal, which is about 2% of our land. This is the glimpse of the mangrove forest, the Sundarban, and that is the longest beach where from you can see both sunset and sunrise. That's a very big one. Thank you very much. Now I like to present the therapeutic application of radioiodine in Bangladesh. Bangladesh started radioiodine practice in 1962 since its inception in Bangladesh, which is run by Bangladesh Atomic Energy Commission. National Institute of Nuclear Medicine, which is the largest center of excellence for academic research and major work for clinical and diagnostic purpose in nuclear medicine. For information, Bangladesh was a iodine deficient area, but now the scenario changed. And after the universal iodination of 25 years, mostly iodine sufficient areas other than few pockets. And we started radioiodine therapy for thyroid patient in mid-60s. That was started in Dhaka Medical College, and it was scattered in 4 nuclear medicine in the another in the Bangladesh, which was in different parts of the country. And after the liberation of Bangladesh, there are about dozens of new nuclear medicine was established. Of them, the National Institute of Nuclear Medicine, which is the Weston. But our practice in radioiodine therapy was very inhomogeneous, and the dose and patient selection that was very different from center to center. But in 2002, the Bangladesh Nuclear Medicine Society, along with endocrinologists, internists, ENT surgeon, oncologists, jointly finalized a protocol for radioiodine therapy management of the thyrotoxicosis patient. And that was published in Bangladesh Journal of Nuclear Medicine in 2002. After 10 years, we have seen there are many things to develop. So Bangladesh Nuclear Medicine Society organized a seminar in the February 2005, and you can see the most of the nuclear medicine specialists of the present in that nuclear medicine conference. And you can see the Professor M.A. Karim and me at that time. I was the Secretary General of the Bangladesh Nuclear Medicine Society. At that time, all the senior people here they managed a seminar and they improved the previous protocol, and that was published in the Bangladesh Journal of Nuclear Medicine. For your information, you know, the Bangladesh, like in other countries, the Graves disease is number one, which is more than 76%. Other thyrotoxicosis, like single or multiple nodular toxic goiter are also present. And before giving the treatment, we take the following matter into consideration for the high-risk patient, like toxic patient, which has got 2 to 3 times higher normal FT4 than cardiac patient, patient with active ophthalmopathy, old age, low iodine 1,3 on uptake with high FT4, patient with very large goiter. You can see a patient with high volume of thyroid. We do the investigation like FT4, TSS, FT3, radioiodine uptake, then thyroid scan by technetium nowadays used, but previously we used iodine for scanning, and we do high resolution ultrasound, especially for the pregnant woman. And thyrotropin receptor antibody TRAF was not done before, but nowadays we are using it, especially in our national institute. Other antibodies and blast tests like WBC, HR, SCPT, serum creatinine also do as a pre-investigation. And the pre-treatment protocol, we use, you see, the Numarcozole 15 to 45 milligram a day, and it's continue until the patient is mildly toxic or euthyroid. Then you withdraw the Numarcozole for 3 to 5 days and give the radioiodine therapy. The dose usually in Graves' disease is this modified dose we call 10 to 15 millicurie, and for nodular goiter, single or multiple, and single it is 15 to 20, and for multinodular is 15 to 25. So a big dose is given for toxic multinodular goiter. In children, we usually treat with anti-thyroid drug, but when there is toxicity which could not control and drug allergy, in that cases we use 3 to 8 milligram, 3 to 8 microcurie iodine for treatment. You have seen that we stop radioiodine before giving radioiodine, the antithyroid drug. It takes 3 to 5 days, which is not easy to be for a patient who are coming from the village to stay in the hotel. That costs a lot of money. So I tried a study how the uptake during the antithyroid drug, and it was seen the uptake is about at that time. That is before it was, I think, 1995. At that time, the uptake was very good. So I tried to give a radioiodine therapy at that time with my group just after at the day of stopping antithyroid drug. So that was our practice, but it is not well accepted. But I still further research could be done on this matter. And I am showing another publication, effect of single dose of radioiodine therapy on volume. This paper was published very recently, 2018, and 300 patients studied, and you see the 42% volume was reduced in 3 months, and 65 volume reduction in 6 months, and 85% volume was reduced in 12 months. The volume reduction is proportional to the thyroid hormone level in the Graves' disease. That was the finding of our study. And outcome of radioiodine therapy, you can see hypothyroid is number 1, then euthyroid. Some patients remain still hypothyroid that needs further doses and lag behind. The TSS is lag behind and FT4 is normal. In that case, we wait and see. It is another publication, outcome of fixed dose radioiodine therapy in hyperthyroid patient that was done in National Institute of Nuclear Medicine. And we see the follow-up at 1 year, the permanent hypothyroidism in 61% and cumulative incidence hyperthyroidism progressed to increase to about 80% in 5 years. Successful radioiodine therapy attained the euthyroid or hyperthyroid state, and multiple radioiodine therapy needed in 11% of the patient. Fixed dose radioiodine cost effective, and its success rate is almost 89%. You can see there is another publication, outcome of the radioactive iodine therapy in hyperthyroidism, study of 3,097 patients. That's a big study. That study was done from the patient records in 24-hour study. Actually, we have seen the patient was given dose in 91 to 98, in 1981 to 2003, and 94% needed single dose in 5 years, and 26% up to 3 doses. Ultimately, most patients became a third. Actually, at that time, we use low doses and calculated dose. So low and calculated is the assessment is lower than the higher fixed dose. There's another study, importance of spacing between radioiodine dose in the treatment of hypothyroidism, when we'll start the second or third dose. We have seen it is better to give radioiodine after at least 6 months. That may go for after 1 year or 2 years, but at least 6 months. That should be choice from case to case. The patient burden in our nuclear medicine establishment, we have seen in the last, we have given therapy in last a few years. I mean, last from starting, that is 15,000. The highest number is in our institute where I work, National Institute of Nuclear Medicine and Allied Sciences, that is 8,406. Presently, neglected and complicated patient is much less as it was before. I think because of this is because the awareness and the facility, increasement of the facility. Experience with children, adolescent. We have very good experience. Radioiodine is safe and effective for the thyrotoxic in childhood and adolescent, and suitable as good as second line therapy for patient with severe complication. Actually, we take, after giving radioiodine therapy, 5 to 7 days to have patients about patient radiation safety. We don't do hospitalization. We advise the patient to avoid close contact with, especially for the women and children, pregnant women and children, use of separate bed, drink plenty of fluid and void frequently, chew sour candy, flush toilet twice after use, bath shower every day, use separate utensil, don't feed a child or a cook, avoid pregnancy for 6 months. And all these things in this booklet we given to the patient written in our Bengali language and mother tongue, so the patient can understand easily, and the patient consent and prescription, a follow-up, everything is written in this book, so the patient can understand easily. We also treat acute thyroiditis, and we see that after diagnosis by hormonal analysis, radioiodine uptake, technetium uptake, lab test, blood picture, clinical evaluation, we give them a painkiller, CD, propranolol, and 50% patient is cured usually. And some patient needs longer treatment, some patient may need steroid. We also treat strom after radioiodine therapy, carbimazole given 20 to 30 milligram every 4 to 6 hours, then IV propranolol in schedule, or sometimes use a small lol, and this is just going on. And saturated iodine of potassium iodide, 5 drops orally every 6 hours on or after antithyroid drug started, and hydrocortisone IV, then other supportive treatment also given. In conclusion, I like to say that Bangladesh has a long history of radioiodine therapy with its success, and it has shown very effective and safe. Can be used at any age and sex. Fixed dose, as good as calculated dose, even better in single use, and cautiously used in old cardiac and exophthalmic patient is needed. Of course, radiation safety is always always needed. And thank you very much. This is the World Thyroid Day. We gathered the Thyroid, Bangladesh Thyroid Society. We have, we're in, you can see in front of our National Institute of Nuclear Medicine and Allied Science. Thank you very much. Finally, I like to thank my co-author, Professor Jinat Zabin, Nurun Nahar, Ryan Hussain, and Fatima Begum. Thank you all, and very good evening and good night to you all. Thank you.
Hello, I am Qaisar Siraj, consultant in nuclear medicine at the Farwania Hospital in Kuwait. The title of my talk is Dual Tracer Radionuclide Imaging in Hyperparathyroidism, Thallium-201 Parathyroid Scintigraphy Revisited. The outline of my talk is as follows. We will discuss the parathyroid anatomy, embryology, and physiology, briefly followed by clinical context of hyperparathyroidism, parathyroid gland imaging, the radiopharmaceuticals being used, the scintigraphic techniques, planar thallium imaging, followed by planar sestamibi imaging. Then we will show you SPECT-CT imaging and some cases, and go to the topic of revisiting thallium parathyroid scintigraphy. And I suggest in the end a tailored approach to radionuclide parathyroid imaging. Parathyroid glands are two pairs of glands, superior and inferior glands, but they can vary. They are usually 4 in number, but the glands can vary from 2 to 6, 30 to 50 gram in weight. They're located over the posterior aspect of the thyroid, over behind the middle and the upper 1/3 of the thyroid, and behind the lower pole of the thyroid. And they're composed mostly of chief cells, which are responsible for parathyroid hormone secretion, and a smaller number of oxyphil and clear cells. Embryological origin of the thyroid, parathyroid, and the thymus gland. The superior parathyroids develop from the 4th pharyngeal pouch, whereas the inferior develop from the 3rd and migrate downwards along with the thymus to the lower pole, where the thymus keeps on migrating, and that's why inferior parathyroids can have variable ectopic locations. The ectopic locations can be anywhere from the angle of the jaw to the base of the heart, and there is an incidence of 5 to 20%. And you can see the various locations could be undescended, retropharyngeal, intrathyroidal, posterior, superior, and true mediastinal. Now, the parathyroid, these glands are responsible for calcium homeostasis. If there is a reduction in serum calcium causing hypocalcemia, it triggers calcium sensing receptors, which releases the parathyroid hormone, which acts on various organs, including the bones, the kidneys, the liver, and increase the parathyroid hormone, increase the calcium levels, and restore the calcium balance. The classical symptoms of hypercalcemia, known as moan, bones, Crohn's, and renal stones involving the gastrointestinal system, skeletal, neuromuscular, and renal, are no longer seen because of the current status of early laboratory diagnosis. The patients are mainly asymptomatic with normal or borderline sporadic elevation in serum calcium with an inappropriate, a low elevation, but elevation nonetheless in PTH. This is what is called the eucalcemic or normocalcemic hyperparathyroidism. It is mostly caused by parathyroid adenomas, which are frequently chief cell adenomas, and less frequent are the oxyphil or oncocytic adenomas, and rarely they are water clear cell adenomas. And cystic adenomas are nothing but a parathyroid, functional parathyroid cyst. Parathyroid hyperplasia can also cause primary hyperparathyroidism. The chief cell hyperplasia is common, followed by rarely by water clear cell hyperplasia. Now, the rationale of localization of parathyroid is a good surgeon can always easily excise the parathyroid gland very nicely. However, with the advent of minimally invasive surgical techniques in 1990s, the Classical neck exploration has been now replaced and together with accurate and sensitive preoperative localization technique and with the rapid intraoperative parathyroid hormone level assay together with intraoperative gamma probe localization of the culprit parathyroid lesions have revived the need for preoperative localization. Here is the gamma probe and here is the images from the radio guided minimally invasive surgery. Appreciate the small scar. So when you compare the classical neck exploration with minimally invasive surgery, bilateral neck exploration is experience dependent. It can miss ectopic glands in around 10% of the patient and it has associated complications like persistent hyperparathyroidism, nerve injury and bleeding, whereas the minimally invasive surgical approach, you make a small 2 to 3 centimeter incision. The complications are much less. Is a fast operating time, can be performed in local anesthesia and as an outpatient procedure. So we have two modalities for parathyroid imaging, the structural and the radionuclide. The structural include ultrasound, CT, lately 4D CT, MRI, and rarely angiography. With radionuclide imaging started with selenium-methionine, followed by thallium subtraction scanning, and lately maybe parathyroid scanning. And you, of course, with the advent of new instrumentation, you've got SPECT and SPECT CT, and where available, PET CT can also be performed. The radiopharmaceuticals initially introduced were cyanocobalamin and selenium-methionine. The mechanism of localization is incorporation into the proteins. Next came thallium technetium subtraction scanning, and thallium being a potassium analog is taken up by the parathyroid cell. Maybe a tetrophosphine mechanism is non-specific and the localization depends on blood flow and mitochondrial uptake. The selenium-methionine was introduced along with cyanocobalamin in 1960s, but they had poor biological and imaging characteristic. In 1980s, thallium technetium subtraction scanning was introduced and it became the first practical parathyroid imaging agents, but only planar studies were being performed at that stage. And when MIBI was introduced, it superseded the thallium and everybody abandoned it. In 1990s, it is a lipophilic cationic radiopharmaceutical being used for myocardial perfusion imaging. It accumulates in the parathyroid and the thyroid gland with a slower washout from the parathyroid gland and has since become the standard radiopharmaceutical for parathyroid imaging. The MIBI parathyroid uptake is dependent on mitochondrial rich oxyphil cells, which are responsible for the avid uptake and slow release of MIBI. And there is a prolonged retention in the mitochondrial rich tissue of parathyroid adenomas or hyperplastic parathyroid. And the washout time from the parathyroid is longer than that from the thyroid, resulting in selective retention of the tracer. But the sensitivity varies tremendously because of interinstitutional as well as patient biological factors. Now we start with the thallium or the other modality, dual isotope subtraction scintigraphy. You can image and you can image the thyroid and the parathyroid with either thallium, maybe or tetrophosphine, subtract and image the thyroid with pertechnetate iodine and subtract one for the other, and luckily you'll be left with a parathyroid adenoma or a hyperplastic gland. So these are some early images. This was way back in 1980s. This is a 23-year-old girl with primary hyperparathyroidism, failed parathyroidectomy, presented in 1986. And this is a thallium scan, and this is a technetium scan. And here in the end, you can see a very big parathyroid adenoma in the left thyroid lobe. Another old case of a 35-year-old man with primary hyperparathyroidism and renal stones, with ultrasound showing 2 nodules behind the right lobe. And here we have a thallium scan, shows uptake in the right upper lobe, and technetium scan shows uptake in the right lower lobe, and the subtraction scan shows intense focus of activity in the right. So a case of a thyroid adenoma and a parathyroid adenoma in the same patient. So now we have, of course, evolved to SPECT CT, and I'll show you this for the earlier cases, and this is a current case in a patient with primary hyperparathyroidism, a per-technitate scan, followed by an early maybe scan, followed by a delayed maybe scan, and a washout image, which shows retention of uptake in the left lower pole consistent with a left lower pole parathyroid adenoma. And the next one is a SPECT CT of the patient, which shows beautiful localization of the adenoma. And this is a case of an ectopic midline retrosternal parathyroid adenoma. Now we come back to the thallium scintigraphy. And in our initial studies, we had some cases where the maybe scans were negative, but we did remember the patient has had a previous thallium scan, which was positive, and therefore we started in those days of the planar imaging, we started to try our luck at doing a thallium scan. This is a case, a representative case. Here we have got the maybe at 10 minutes and per technitate, and the subtraction scan is negative, whereas we do perform a thallium scan and this technetium subtraction, and we are left with a right parathyroid adenoma. Excuse me. And the patient was taken for surgery, a collar incision was made, right thyroid lobe was dissected, and a 0.8 gram right parathyroid adenoma was removed. It is a case of a maybe negative thallium positive parathyroid adenoma. And the gland was sent for histopathology, and there was no P-glycoprotein expression seen in this, which is supposed to give a false negative maybe scan, but we did not see any P-glycoprotein expression. Another case here of a patient with primary hyperparathyroidism and with raised calcium and parathyroid hormone, per technitate scan, maybe scan, and delayed maybe scan, and the SPECT CT scan also was performed, but this was all negative and no adenoma was seen. We repeated this patient with a thallium technetium per technitate subtraction scan, and you can nicely see there is a left parathyroid adenoma. On surgery, the adenoma was dissected, and again it was maybe negative thallium positive parathyroid adenoma, and again there was no P-glycoprotein expression documented on histopathology. So there are various factors which affect maybe uptake. It could be the size of the adenoma, mostly the cell type, because oxyphil cells are responsible for maybe uptake, whereas chief or the water clear cells are unlikely to take up maybe. And of course, the mitochondrial structure, the cell cycle of the parathyroid gland, and the P-glycoprotein expression are supposed to cause false negative maybe result. This is a recent study under publication, online publication, where we did dual tracer radionuclide imaging in hyperparathyroidism, being published in the Nuclear Medicine Communication. And I will give you the results of the study. The objective of the study are as follows: as there are multiple factors that adversely affect the accumulation and retention of MIB in the hyperparathyroid lesion, it can result in which can result in a false negative scan. The study aimed to investigate the possibility of an incremental diagnostic role of thallium-201 parathyroid scintigraphy in patients with presumably false negative technetium maybe scan results. There were 22 patients with hyperparathyroidism where the maybe scan was initially negative, inconclusive, or where additional lesions were suspected on the SPECT CT scan, with the CT component identifying lesions without significant technetium maybe uptake. The results of the study shows that further imaging with thallium-201 SPECT CT scan showed 46.5% additional lesions in all patients with hyperparathyroidism in this study. In patients with primary hyperparathyroidism, Further imaging with thallium-201 showed 59% additional hyperactive parathyroid lesions, and in patients with secondary hyperparathyroidism, further imaging with thallium SPECT-CT showed additional 33.3% of hyperparathyroid lesion. So we concluded the results of this pilot study strongly advocates a role for thallium parathyroid SPECT-CT imaging in patients with primary and secondary hyperparathyroidism, where the initial technetium maybe scan is deemed to be false negative in the presence of biochemical hyperparathyroidism. And these are the scans from this study. This is a case patient, 53-year-old female with primary hyperparathyroidism, pertechnetate, early and late maybe, and the pertechnetate and early maybe, and the subtraction scans are both negative. And here we have got maybe SPECT-CT scan images showing a right parathyroid adenoma. We repeat the same study with the technetium, with the thallium-201 SPECT-CT scan. It equally, with equal sensitivity, it shows the right parathyroid adenoma. So in this case, both the thallium and the maybe SPECT-CT equally are avid for the parathyroid adenoma and are equally good. Now, this is a patient with primary hyperparathyroidism, and you can appreciate the MIBI scan shows uptake in a right upper parathyroid gland only, whereas the larger right lower parathyroid gland here with the red arrow does not show any uptake. You repeat the scan with a thallium, and you can see now uptake in both the larger right inferior and the smaller right upper parathyroid gland. So this is a case of double parathyroid adenoma. One is thallium avid, but maybe non-avid. Both maybe and are maybe and thallium avid. So first case was equal avidity for thallium and maybe. Here we have two adenomas with both avid for thallium, but one, the bigger adenoma, not showing any maybe avidity. Another case of patient with primary hyperparathyroidism, and this patient has maybe uptake in bilateral lower parathyroid glands. But when you repeat this patient, he has now uptake in all the 4 parathyroid glands in this patient, and this is a case of 4 gland hyperplasia. Only 2 were maybe avid and all 4 were thallium avid glands. A case of a 25-year-old with secondary hyperparathyroidism, and maybe planar and SPECT-CT scans are both normal, whereas the thallium SPECT-CT shows 3 gland hyperplasia. So we come back to a situation where we have, in a patient with hyperparathyroidism, we have a tailored approach. If the patient has primary hyperparathyroidism, we perform a pertechnetate maybe scan at a normal resolution. With secondary hyperparathyroidism, we obtain a higher resolution SPECT-CT scan, and if they are positive, you go for parathyroidectomy through medical therapy, depending on what the result is, what the cause is. And if they are negative, you should go for a thallium-201 SPECT-CT scan and go for the treatment. And in some time, because of the cell cycle, you cannot see the gland in both the imaging modalities, and then it is best to wait till the PTH rises, or wait for a suitable duration, around 3 months or 12 weeks. So now we have reached a full cycle. We used to do thallium scan. It was replaced by the MIBI scan. However, if now the MIBI scan is negative, we would advocate a thallium scan. And of course, SPECT-CT has the advantages, and PET-CT has a better resolution. You can have combination techniques, patient-tailored techniques, and for primary and secondary hyperparathyroidism. Thank you.